Fine.
I don't know how you cope and do all these things. You know, each time I see you still look the same. I don't know how you cope.
Yes, and we have the CCOP meeting next year in Egypt.
Yes.
In November.
I'm already planning for it, so I'll be in touch. There are a few things.
Yes.
I'll message CCOT, and for the limb reconstruction committee, we can plan something, and also one or two other things. I've been thinking,
Please include Peter, because he wants to come to Egypt again. I know.
No, Peter,
I see that in your eyes.
Egypt.
Hi, Peter. How are you doing?
No, I'm brilliant. I'm brilliant. I mean, I have to be honest, it's very busy at the moment. For the first time ever, I found that I haven't got enough time to do what I want to do, because the hospital is very busy. My other role as the medical director is becoming quite challenging. I've got, you don't realize how hard you work, but how little anybody else works, and how there are so many people who have lots of problems, but they offer no solutions. They just moan.
I got it. I used to deal with people like this. Yes, I used to.
Yeah, I'm finding it. Because I don't mind having problems, but how can we help you achieve things rather than, okay, it's my problem now, so I'll solve it. You need some partnership with these people to try and make it work, and it's just really hard work at the moment. And of course, the big problem with, I'm sure it's the same in Egypt, we have a big problem because with our free health service, the priority has been given not to orthopedics but to other specialties. And so so orthopedics is really struggling to get capacity to do work. So I don't know if that's true in Hull, Hemant.
I mean, imagine you are an elective hospital and you are having such difficulties. We had no chance for next 3 months. It's unlikely we'll operate any elective patients, only trauma.
No, we are full. We are full, and we are back to pre-COVID levels. But the management want us to work at 106%, because if we work at 106%, the government will give the hospital money, and so the management their expectation is that as surgeons we will say, oh yeah, fine, okay, we will do more work, but
yeah,
we're not. We don't want to work that. I don't want to work on the weekends anymore. Because the other thing that they don't seem to understand is that surgery is not just about the operation. There's little things called post-op recovery, rehabilitation, and it's not just about, oh look, we've operated on 10 people today. Yeah, it's 10 people, but has everything gone well? I went onto the ward yesterday to do an operating list. There were 6 people on the list. I could not find a single set of notes. Not one set of notes. Couldn't find the consent. The consent had been done by the team. I was just going to check them. Could not find a single set of notes. It was ridiculous.
No dear.
But anyway, that's enough of our problems.
Yeah, that's right. Just before we start, let me introduce Dr. Ashraf Azer. He's a consultant in rehabilitation medicine from Liverpool.
Hi.
Nice to meet you.
Hi, Sharma. How are you?
We haven't met. I'm from other side of your road.
Oh, are you? From where? From?
I'm from Hull, so we are on the other end of
Hull is the other side. Yeah. And I've heard about Mr. Calder as well, because
good friends. So
good friend with Hemant.
Yeah.
Excellent.
Hi, Dr. Ashraf. Good to see you.
How are you, sir? How are you? You're okay?
Fine. Where are you from originally?
Good to see you. From Egypt originally.
Yes, you look 100% Egyptian. No hair and 100% Egyptian.
It's a typical.
Typical Egyptian, 100%. Yes.
You can't say that.
I just want to ask Mr. Calder, how did you like the food? It's absolutely amazing in Egypt.
Oh,
that's it.
No, So I was fortunate that so I was asked to go and lecture in August. And I said to my wife, I said, would you like to go to Egypt again for the weekend? Oh, yes, she said. Right, when are we going? I have to say, we were very lucky. We went to Shakra. Where did we go?
Saqqara.
Pyramids.
And we were taken to some tombs, and it's the most inspirational thing I've ever done in my life. It was unbelievable.
Brilliant.
And
glad that you like it.
So we are. So many people are jealous. So many people are jealous, and to the extent that people are trying to book trips to Egypt, and we're saying to them, yeah, but you got to know the right people.
Absolutely, the people you know that.
Yeah, exactly. You know, you can go and see the pyramids, but you got to go and see the pyramids. You know, you got to go, and so
from outside.
Well, yeah. I mean, it's unbelievable. So yeah, Egypt got a very special place in my heart. So it's very good.
Oh, that's very kind. So next time, Mr. Sharma, then we'll go there.
It's always a pleasure to have you all together with us.
Thank you.
Ashraf, you have to come.
Yeah.
Can I just ask? My talk is bound to overrun. Hemant, you're going first, aren't you?
I have no idea.
Oh, okay.
No, I'm the first one because I'm going to criticize everything on earth.
No, then you go last then. Gamal, you can't go.
This is the critic's mind, my critical mind. You know this.
No, we can't let you go first. Otherwise,
yeah.
And I'm Ahmed, just to check with you, I'm doing just basic ideas of limb reconstruction implants rather than.
Yeah,
I'm not doing anything. I'm not doing any research or data or anything like that. I'm just giving ideas about how you correct what you can.
Yeah, it's more about principles. Yeah.
Yeah.
Okay.
Can we start, my dear professors?
Professor Muhammad, yes.
Bismillah ar-Rahman ar-Rahim. It's a great honor for me to announce for the start of this webinar, gathering a great collection of Egyptian and UK eminent professors in the field of deformity planning. This is the third year in our webinar, online webinar and online course. We have made more than 350 webinars all over the 3 years, containing many of national and international guest speakers. These webinars were all recorded and on our YouTube channel, which is have now in this day more than 6,000 subscribers and more than 250,000 views. All our webinars were transferred live on the Ortho TV channel to India and Southeast Asia, and viewed by more than 2,000 to 3,000 orthopedic surgeons from India and Southeast countries. It's a great honor for me to announce for this webinar. Our eminent professors will be Professor Gamal Hosny, the president of the Egyptian Orthopedic Association. Of course, Professor Hemant Sharma from Hull University. Professor, my dear Professor Sharma, this is your third time with us in the course. It's a great honor for us, sir. Mr. Peter Calder from London Royal Hospital. Thank you so much for joining us, sir. And lastly, Dr.Ashraf Azer from Liverpool, my dear friend. Thank you for joining us. The moderator of this webinar will be Dr. Ahmed Sheikh, my dear friend, and the cornerstone in this webinar. Thank you for your effort, Dr. Ahmed. We will start with the presentation of Professor Gamal Hosny. Professor Gamal.
First of all, I would like to thank Professor Mohammed Lashab, the Dean of Banha University, for this great work. And also, I would like to thank Ahmed for the moderation of this session. Thank you so much. I'm quite happy to be with my friends, Hemant Sharma, Professor Hemant Sharma, and Mr. Peter Calder from England, and also Dr. Ashraf Azer. He's originally from Egypt, is working and is working in England now. It's a great pleasure to have you all in this session. You know, it's a skeptic's mind. It's rather criticizing what we are doing in limb lengthening. It's a skeptical attitude. It's just, I have to criticize everything now, just after being working in limb lengthening for 40 years. And I have seen things from different point of view, and I will show you my different point of view. We all know that limb lengthening continues to be a real challenge for both the patient and the orthopedic surgeon. It's not a difficult operation, but it's an exhausting post-operative procedure, which can jeopardize early good results also. What's the aim of lengthening? It's limb lengthening, it's correction of limb length inequality, functional improvement, or just cosmetic lengthening. I don't know if you go through the internet and you are going to go through the States, Germany, Italy, you'll find hundreds of videos, hundreds of press conferences talking about cosmetic lengthening. Many people talks, all their talks about they are the best surgeons of limb lengthening in the world, the most experienced limb lengthening surgeons in the world. A bit strange. Why in limb lengthening? And they all talk about operation without complication. All of them, 0% complication. Most of them, they talk about lengthening nails. This is the real magic. And if you want to do lengthening without lengthening nail, that means they are an old-fashioned surgeon. And you have to stop it. If you don't believe me, go to the internet, look to the YouTube channels, hundreds of videos. What about the indications? In old Egypt, we don't have many indications. Why? Because many of the divine protectors in the pantheons were deformed. Bes, God Bes, and God's Betah. And they were the society attitude to the deformity. There was no discrimination. This is the old Egyptian values, no discrimination. So look here to the belly dancers in the temples, and we have a short one. She dances normally. You know, there was no discrimination between short people or dwarfs and the normal people. Snip was a very important man, something like prime minister now. He was very rich, married to a normal girl. He has 2 children, normal children. So in old Egypt, the pharaonic time, we didn't think that we need lengthening because they were treating short people normally. What about the biology of limb lengthening? Whatever the type of lengthening, whatever the method you use, it's the law of tension stress, nothing new. So it's about more than 60 or 70 years, we are using the law of tension stress, Elizarov law. Under slow and gradual distraction of 2 bone segments following an osteotomy, the stress that develops leads to soft tissue and bone regeneration. Nothing new, no developments. It's the same thing, the same biology. It's latency period, distraction phase, consolidation phase, and remodeling. What's different? When the people talk about the advances, they talk about methods of new external fixation, computer external fixation, intramedullary length. It seems for me like treatment of fractures. When you think about fractures, how are you going to treat fractures? Reduction and fixation. You have thousands of papers talking about fixation. No paper talks about reduction. Why? You have companies behind the methods of fixation. Nothing behind the reduction. So the people ignore the reduction for the sake of it. So when we talk about lengthening, people, when they talk about the method of fixation because there are companies behind. So they talk about external fixator, computer-assisted external fixation, and intramedullary lengthening. And they describe it as the new revolution. And the example that you are coming to a party with an old Fiat or another one coming with Ferrari or Bentley or whatever you do. So the people talk about recent advances. It was not, this is these are not the recent advance, just changing the type of fixation. And they describe it as the recent advance. I don't know why. And when they describe limb lengthening, they group it together. So when you lengthen a child, 3 years old, for 3 centimeters, exactly like you lengthen 20 years old man with 6 lengthening, or another guy, 34 years old, for 22 centimeter lengthening. This is lengthening and this is lengthening. So you use something and you describe it a huge success for lengthening for 3 centimeters. And you say this is a huge success. Why don't you compare it for 22 centimeters? No one do it. This is the illusion of evidence-based medicine. I advise you to read this paper. The illusion of evidence-based medicine. Evidence-based medicine has been corrupted by corporate interests, failed regulation, and the commercialization of academia, argue these authors. And limb lengthening, this is the real application of the illusion of evidence-based medicine. This is the real illusion. Because when you read the papers about different types, people, they always talk about evidence-based medicine, evidence-based medicine. And I can assure you, 100%, this is non-evidence-based medicine. Most of our practice is non-evidence-based medicine. So, and this is an example. Although lengthening nails are marketed as a breakthrough technology in limb lengthening, limb reconstruction, that avoid complications associated with external fixation, there is no substantial evidence to confirm this claim. But they repeat the same words again and again and again. Not even that. You can see press conferences. Can you imagine? The breakthrough is depending upon the press conferences, not on the papers, not on the scientific ground. So if you talk about lengthening nails, now we have 2 widely used nails, the precise and the magnetic nails. And they always say that these nails avoided the complications of X-fix, avoided the complications of X-fix. It's okay. How many times the X-fix was recalled? Nothing. There was no recalling of X. But to have recalling of ISKD in 2012 and recalling of a stride precise nail in 2020 or 21. I remember that the press conferences for the stride nail 2 or 3 years before, press conferences calling it the nail, the mother, this is the nail of the mother of all the nails, and everything else on earth has to disappear because this is the real advance. And within 2 or 3 years, they recalled it because of lots of problems. Going back to the magnetic nail or Baumgarten nail. And I read this paper 2 or 3 months ago in the Clinical Orthopedic and Related Research, talking about how successful the antegrade nail for femoral lengthening, how successful it was. And look, I wrote this letter to that. It's published this month in Clinical Orthopedics and Related Research, talking about this paper, which describes the breakthrough of the magnetic nail or Baumgarten nail in doing bone lengthening. Baumgarten nail is in the market now for years and years. So the first thing, a retrospective study for patients age 14 to 17 years of age, adolescent patients. And the lengthening magnitude, 3 centimeters to 5 centimeters. Very short, small segment. The patient stayed in the hospital from 6 to 10 days. Remember, in our patients, the patients stays in the hospital for a few hours or stay only one overnight. The median time from the date of surgery to full weight bearing was 108 days. Can you imagine? Staying in bed for 108 days for an adolescent, just to have 3 centimeters lengthening. All the patients has another secondary operation, and they wrote, this is not a complication. Can you imagine? exposing a guy 15 years old to another operation after 1 year. All the anesthesia and image intensifier or the radiation hazards, and they don't call it operation, complication. 76 of patients reported complications, including deep infection for patients, non-union for patients. What's this? A knee dislocation on patients. But they call it a successful operation. 20% of patients underwent unplanned additional surgery. Can you imagine? What a huge price to pay for such a small gain. And finally, you have press conferences, you have repetition of the same words about the new revolution and the new breakthrough in limb lengthening. And it's science made by the companies. It is 100% biased ideas. You can read my opinions in the Clinical Orthopedics and Related Research this month, 12 months. So my criticism, I grouped my criticism in 4 papers I published from 2020. This paper, The History of Limb Lengthening, and the Italian journal, this paper, the Journal of Orthopedics and Traumatology, 2020. This is the Clinical Orthopedics and Related Research this month, December. This meta-analysis, I did it with my group about the complications of lengthening nails. And this is meta-analysis. And at the end, we found out we don't have any advantage. It's just talks, just repetition of the same words again and again and again. Nothing. It's non-evidence-based medicine. And also limb reconstruction resource limited environment in the Journal of CICOT at the beginning of 2021. In conclusion, in spite of the introduction of promising intramedullary lengthening nails and computer-assisted fixation, we still count on the result of biologic law. Nothing has changed. It's the same. It's the same practice. Biologic advances through research to stimulate regeneration and reduce the period of treatment will be the real revolution. If you want to make a revolution, you have to spend money in that field. But you don't want to, because there's no money back. There are no revenues on this. What's the problem? I think the problem in my mind, the skeptic's mind. Perhaps this is the real conclusion. Thank you.
Thank you so much, Professor Gamal, for this very interesting presentation. Dr. Ahmed, if we have any questions to Professor Gamal.
Thanks much, Prof. I think it's beyond the level of questioning, really. It's a very different point of view in assessing what we have achieved in the world of limb reconstruction. Just my little comment. I think the point of view or the angle or the perspective of the patient in different geographic areas might have a little influence on the understanding of the whole issue. From the scientific view, as Prof. Gamal said, there might not be a big evidence that this is better than this or whatever, but I think after discussion with the patient might opt for something that might be less maybe ugly for him or something like this. So there might be some differences between the patient expectations in different parts of the world. So this may be one of the things. That's my little
I agree.
Experience.
I agree with you entirely. Why I agree with you? How the patient had this opinion, how he get this information from press conferences, from the internet, from the YouTube channels, which are all fake. They are all made by the companies. They are all made by surgeons talking about 100% results without complications. One of them said, I've done hundreds, I'm the most experienced man of the world. I have no, yes, because he has animation-based classifications. He has animation-based experience. If you have animation-based experience, you have 0 complications. But if you do thousands of patients, you do have complications. Look, go to the internet now and just write stride nail. stride precise. Now they call it stride nail. Not at the beginning, they call it stride precise. But after this problem, they removed the name precise. Look to the press conferences made before and after. Hundreds of press conferences talking about this is the real revolution in history. And the stride nail has to replace all the methods of treatment. And after the recalling, hundreds of press conferences talking about the very few complications, but they have to remove it because they need to do more or something like this. So I agree with you 100%. You created this. This is the world of the companies. The companies created this world. And the patients, they don't read the scientific journals. The patients, they listen to the YouTube channels, they listen to the press conferences, and those people have their own ways. They have all professional ways, have to make the paper. This paper is opened. Who is going to pay 4,000 euros for the paper to be opened for limb lengthening? The companies. So when you want to write a paper about limb lengthening, you go for open journals. When you go for the open journals, you just take it and put it in the references. And now you have the citation index more, you have more H index, more propagation of the ideas. And this is the real issue. This is the way how we create the conscience of the patient, how we make them convinced with the nails. What do you think, Ahmed?
No, just from my experience as a fellow with Peter, we have a very scientific discussion with the patient, but this is in the NHS. I can't comment on other services. We have very scientific discussion with the patient about the advantages, disadvantages of everything and possible complications. And really, we haven't promised anyone with 100% surgeries in the NHS with Peter and before with Liverpool, and I'm sure with also Prof. Sharma. So that's why there are differences between the things. I think the commercial-based services might have another attitude. I don't know, but just that's my little comment from my little experience.
Okay, thank you.
Thank you so much, Professor Gamal. Now we will move to the next speaker, Professor Hemant Sharma from Hull University and one of the eminent stars in the shining sky of deformity planning science. Professor Sharma.
Thank you so much. And that's very kind of you. And Egypt has always been a special place. I think it's my second home. Number of times I've traveled and I've so many friends I have. So, but I'm very grateful for the invitation and to give me another opportunity today. I'll talk about a little bit less controversial in my talk, and I'll be focusing on the just basically around foot and ankle a little bit and discuss some basic principles. I hope that we can discuss some of the basic problems, and I will give you my systematic approach, a very pragmatic approach. It's mainly, my practice is mainly adult based, so pediatric I won't talk a lot. And the Charcot feet are completely different ball game, so we will not be talking about those, although some basic principles will apply on that. So if you look at the feet, there are multiple segments where the problems can happen. You can have the equinus at the ankle. You can have a subpillar problems, which can go to varus valgus. Then you have a midfoot problems. You can have rocker bottom or cavus. And all these things in general is to identify that there are multiple components of the problem, and each component has to be identified. And I think the most important thing would be a tripod. And I think a normal tripod or abnormal tripod will direct our a treatment plan in a very different way. I suggest when we see foot and ankle, like any other limb reconstruction, any other lower limb reconstruction, I would suggest we must do a full clinical examination. And the important thing is we need to identify there are a lot of interrelated problems in the foot. One problem can lead to another problem. They can be compensatory deformities, or they could be deformities which are initiated by the primary problem. And in addition, we need to look at if there are any leg length discrepancy and any secondary problems which we have, and that needs to be identified, addressed, and tackled at the same time. X-rays are actually quite critical, and the hindfoot alignment is actually pretty important, because ankle X-rays are easy, and sometimes we miss the hindfoot problems, which may be the cause or maybe the effect of the primary problem, and identifying them would be quite is extremely useful. There are a number of angles, and I won't go through all of them, but basically there are simple few things we need to know: how the calcaneum sits with the foot, what does the normal arch of the foot looks like, what is the alignment of this to the tibia, what is the metatarsal declination angle, and all this is important that when we're planning to recreate a foot. Although I must emphasize that X-rays are the least important part of the foot and ankle treatment. Then we look at the center of the foot, which is slightly, the mechanical axis is slightly medial to the base of the second metatarsal. And the important thing is that the straight line from the second metatarsal is the line which we should align everything to. There are a number of things, a number of people you need, but I think the most important person in foot and ankle surgery is an orthotist, because the insoles, shoes, and all those things are extremely important, and often those are very helpful to eliminate a lot of pain, and we can avoid in surgery in a lot of these patients. I think it's very important that we identify the components of the problem. When we look at it, we describe the deformities equine equivovirus. But it's quite important that if you identify these deformities and break down into smaller problems, they are much more easier to tackle and treat. The other thing is that the foot and ankle is one place where the least intervention, the less we operate, the better it is. All we look at the desired functional result for the patient, and which we should try to achieve with a minimalistic approach or intervention. What we really need is a foot which patient can wear a normal shoe and walk, or even with the insoles, that would be useful. There should be minimal or no pain, and that is a principal aim. Ignore X-rays. We often should ignore, because it doesn't matter what X-rays look like. If the foot is plantigrade, patient can walk fine, I think the job is done. So what are the indications we need to tackle these problems? Now, ankle is one of the commonest problems, and if you see, the ankle replacements are being done in younger and younger patients, and these are failing because long-term results are not there as yet, and they cause significant amount of problems. Charcot foot, which I said we won't talk about today, but butt frame for a midfoot problem is quite useful, and we need to identify if there's any neurological conditions in any of these patients. How we assemble the frame to the foot, you can look at the either they can be the vertical or can be horizontal. So this is they can be at one level. So you can do a midfoot and a horizontal, and there's a tibia. And these are usually used, the midfoot can be used for trauma if you need, although that's not the ideal. Internal fixation works pretty well. But for the midfoot deformities, it works very well. Although if you're doing a butt frame, then we must remember that we need to correct the hindfoot deformities prior to correcting the midfoot, which is mandatory, because this frame will not correct any hindfoot problems. You can reverse the frame and use the calcaneum osteotomy or the calcaneum to correct or the calcaneal fractures actually at times to realign and reshape the foot. You can have a two-level frames which can have different components. They can be in line, they can be orthogonal to each other, or they can be parallel. Now, these all increase the complexity. The idea is we don't have to do it, all of them, but just to understand the principles and what is available to us. You can have a two-level frame vertical, and you can have a one ring or a two ring. And then similarly, you can have a horizontal frame with a one ring, or you can have with a two ring. Two ring in the horizontal frame in the foot becomes very, very tricky and challenging because there is not enough space. So we tend to use the single ring even when we have to do two-level frames, which is usually, in other words, we call something called like a mitre frame. What we can correct, and each frame will have own components which we can correct, and so each part of the frame can be used differently, and we can plan a frame accordingly. So let me give you an approach. How do we tackle these problems? So this 77-year-old, quite fit and well. He had a 4-foot adduction. He had a bit of a avus and some equinus. He's about 30 degrees of hindfoot varus. His first ray was plantar flexed, the foot was pronated, and his head leg length discrepancy. So if you identify all these problems, then it appears a very complex problem. This is a clinical picture, but if you look at it, this clinical picture, we need to break it down, these problems. His principal problem is he walks on the lateral part of the foot and he can't walk far because his foot is painful. So if you look at it, these are all the problems. So let's look at it one thing at a time. Equinus, how can we deal? We can deal with the soft tissue correction and the bony corrections. We can use internal or external fixation. Hindfoot, we can correct with osteotomy or fusion. Internal fixation is easiest, and I'll highly recommend this rather than the external, though you can do external if you want. Internal is much easier if possible. And if you come to the midfoot, we can have a combination of soft tissue and bony corrections, and usually done by external, and the plantar flexor flexion of the first ray is usually corrected by a small plate. So these are the components of the deformity which needs to correcting. And if we start, so this is my preoperative plan in the surgery. There's all of these things we can do, including that we'll end up doing a butt frame and first metatarsal osteotomy. So we started with TA lengthening, did a subtalar fusion, and by the time we did that, equinus was corrected, and with a bit of soft tissue release, everything was corrected. The only thing left was the first metatarsal, but it was so flexible that I didn't think it needed correcting. So ultimately, at this point, we just stopped. We didn't do anything further. And the idea of dividing them into smaller components is that you can continue with, you can do in a stepwise fashion, and you stop when all the deformities are corrected. And he ended up with a simple plaster and no frame. And this is the picture this week. I'm sorry, there were clinical pictures. I couldn't find them, but I can promise you his foot is flat. I can promise you that. I've seen him this week. There are a number of osteotomies you can do. They all become difficult and complicated, and it's up to your experience and what really need. V&U osteotomy will end up giving you subtalar stiffness, and therefore I think pediatric surgeons do it a lot more than the adult surgeons. We tend to do more subtalar fusion and calcaneal osteotomies rather than the whole complete osteotomy. How to do a foot osteotomy is quite a simple technique. Actually, it's a jiggly saw works much better, although osteotome can be used as well. Simply put two wires and put your jiggly saw between the two wires, and then so your jiggly saw will not move anywhere else. It will cut in the line. These wires, you can use it as a stirrup wire and just attach to the rings, and which means your correction will happen only in the at your osteotomy. This is less of a problem in adults But in pediatrics, I understand this is more of a problem. And but the technique of the stirrup wires can still be used. One of the problems you find is the leg lengthening, because a lot of these patients who come are not young. In young patients, it's not a problem. In older patients, it becomes a problem, especially when these failed ankle replacement, which are gradually increasing in my practice. Average, you need to do 2 or 3 centimeters of lengthening. Even that is a struggle. Therefore, I strongly suggest that anybody over 60, we need to be careful that do we need to lengthen it, and can we leave them a couple of centimeters short and give them a shoe raise. We looked at our data and we found that our average lengthening was just less than or around 3 centimeters. It increased the frame time at least for about 3 months. And we have submitted for publication, so hopefully it will be out soon. So lengthening, we need to be very careful and consider do we need to do it. If you have to do it, build 2 separate frames. So each frame can be taken off. So ankle, you always heals first. So take that frame off, leave the leg lengthening frame, and then it becomes much simpler. One frame, we need to plan it in a way that one frame should be independent of the other frame, just simply connected. And this is an example. This is a failed ankle replacement, had a non-new with a bone graft and a nail that failed. So did a frame with lengthening, and here ankle frame is removed and only the lengthening frame is left. And this basically, which is much easier for patient to tackle. What are the problems with the lengthening? Healing is a big problem, especially in the elderly and patients who have multiple comorbidities and the soft tissue problems. So this is a recurrent non-union elderly gentleman. He came to the clinic, didn't take much notice. I completely missed this loosening of the heart pin. And if you look at it, this is loose, and I've got another picture with these wires are loose. Everything was loose, and I completely missed it. And this came around. If you see, there's a big area of loosening. Everything is loosed, and what happens? Your regenerate goes backward and increase the frame time. I had to take the patient back to theater to restabilize everything. So I think these are a number of problems which we face, and I think how we do it is we need to select patients carefully. We can avoid pinch in metaphysis, and need to be in constant review and careful review of the X-rays. And that is one way to avoid the problem. If at all, avoid the lengthening and elderly is not always possible, but if it can, it should be done. Other option is, can we do something else, like plan as a 2-stage frame where we can change the external to internal. We need to do pre-plan it, and that way the frame time is reduced. If we're correcting a acute deformity, we need to be very careful, especially in elderly vasculopaths and diabetics, because what tends to happen is that if you don't do enough shortening, you end up with something like that, and that becomes a problem. It healed up, but it can be a major issue and can cause deep infections. And therefore, gradual corrections, if you don't have to do shortening, would be quite useful. This is an example of a 2-stage. This is again a long-standing recurrent non-union. Didn't want to lose the leg, so we did a 2-stage correction. Stage 1, we corrected, brought it bent over, brought it under the ankle, did some extra lengthening to get some suppleness in the skin. And stage 2, did the fusion. It took a long time, but she has a functional foot. So the primary aim is to correct the deformity and give a plantigrade stable foot on which they can walk. And ankle fusion is often done, although quite often not indicated in these chronic deformities. It's not because of the arthritis, but to give them a stable platform, because a significant amount of deformities can be corrected through the ankle. Especially important if your tripod is normal. If your tripod is normal, then the supramalleolar or the ankle is ideal place. We can correct everything and put the foot in the plantigrade position. How do I approach these cases? I do ankle. If there's infection, I do external. No infection, I do internal. Hind foot, I always do internal if I can. midfoot external, and lengthening depending on external. But if I have a choice of nail, I'll do arm nailing, and I won't tell Professor Hosny about it if I'm doing arm nailing. So this is an example. If you see the problem, tibia valgus, ankle equinus, osteoarthritis, the asymptomatic, hindfoot varus, avus, and pronation. But pronation is flexible. So I've identified all these problems. This is a clinical picture. So I started off, did a subtalar fusion and the calcaneal osteotomy at the same time, and that corrected the hindfoot quite nicely. Went in to do a tibial osteotomy for deformity correction, and did a midfoot frame with osteotomy to correct the midfoot. And it looks actually quite dramatic, but it's actually a very simple frame. It's got only 2 elements to it, and they correct quite nicely, and pretty straightforward frame. And we got a lovely plantigrade foot, straight leg, and now patient there's a heel is in slight valgus, if you can see, and this is what we want. Actually, it's a bit like that. Slight valgus, pain is gone, and so this is my approach to break down the problem and tackle them separately. Pediatric is totally different. I won't talk about this, but I'll give you just an example. If it's a less than 10, just a distraction is enough. If it's over 10 or syndromic feet, then you might need something extra, maybe bony procedure. This is an example of a quite simple frame. This is actually from Michael Laverick, and it's this very, very simple frame. I love his frames. He did such a simple frames and hinges and corrected beautifully all deformities, plantigrade foot. And this is the final outcome. And this is a lovely chapter which is written by Franz Alex and Mikhail. If you want to read it, quite useful for the foot and ankle frame configurations. So in summary, it's a complex problem, and I think we need to be pragmatic about in our approach. We must ensure that we give what patient wants, a plantigrade stable foot where patient can walk and hopefully pain-free. Break down the problem into smaller problems, tackle each problem separately, identify that if one problem, what is the effect of one problem to the other? And if you correct something, what is the effect of that correction to the other problem? Minimal surgery, stepwise systematic approach, always slightly overcorrect. And can I invite you to the next year's deformity course, which is in June, which you are well aware. But other thing we need to, just to mention is that we have just about to, it is finished. I have seen the copy. It's not available to download. Hopefully by next week, it will be on our website. It is free to download to anyone. Just need to go on the website, register, and you can have free deformity planning, fundamentals of low limb deformity analysis, not a book, which is available to free or to anybody. Thank you so much.
Thank you so much, Professor Hemant Sharma, for this marvelous talk. Thank you so much, sir.
Thank you.
Dr. Ahmed, if we have any questions to Professor Sharma?
I have a question, really. Thanks so much, Prof, for this holistic. It's really impressive how can we divide the thing into many, many details, then we can approach everything on its own. My little 2 questions. You mentioned something about switching from the external fixation to internal fixation. I always have a fear of infection. So even if the pin sites looks okay, how do you do this? Do you remove and put the internal fixation a few weeks later, or do you rely on blood tests, or what's the safe way to our best that can we do with this?
So blood tests are pretty useless. They actually don't show us anything. So I really don't do them. I think what the most important thing is the planning. So for example, let's say we are doing a hindfoot nail. So your wire should be above 200 mm, because then you have option of 150 and 200 nail. Then your hindfoot wires in the calcaneum should be posterior and in the front. So the whole track of the internal fixation should be separate from the external, and those two shouldn't touch each other. Now, for example, if there is a wire in your way, then all I would suggest is just take a over drill a cannulated drill, over drill the wire, leave the wire in, over drill the wire, and then take the wire out and wash it. Still, there is a risk that can happen, but the chances would be minimized. But the most important thing is the planning of your internal fixation, so that you can plan your frame accordingly and put it well away from the internal fixation zone.
Yeah, thanks so much. Yeah, that's good. The other little question about the last case that you showed, lengthening with the foot frame. You did the osteotomy mid-diaphyseal. Does this worry you in the terms of the quality of the regenerate in comparison to the metaphyseal one, infratubercular?
Yeah, so normally for lengthening, I wouldn't do it there. It was principally because of the deformity was there, the apex of the deformity was there, and the lengthening wasn't too much. So it was the best place. But generally, I completely agree with you that the lengthening should be done at the metaphysis. Diaphysis do worry me. Yes.
Thanks so much. That was perfect. Thanks so much.
Thank you so much, Professor Sharma. Thank you so much, sir.
Thank you.
Our next
Can I have a
speaker
question, Professor Al-Ashraf?
Yes, please, Dr. Ashraf.
If you don't mind, just Professor Sharma, it's a lovely, excellent presentation. Thank you so much for that.
Thank you.
Just I have a question because I have an interest in diabetic feet and wound, and I was just actually teaching on foot biomechanics before coming here. My issue is that with calcaneal osteotomies, my background is orthopedic, I do rehabilitation medicine. I have an issue with calcaneal osteotomies or calcaneal partial amputation of the calcaneal, partial calcaneectomies, and in weight bearing and in functionality of the foot after being discharged. What's your views about functionality as an outcome measure? How would you measure it? Because we often see diabetic feet with less frank, Chopard, but very little knowledge about muscle balancing, about things like Pirigoff or Boyd. And then we face a patient who, yes, he has so much complicated surgery, but with no function or very, very little function. So what's your views about that?
So in my practice, we do a lot of infection and a lot of Charcot work. And one of the things I have avoided up till now is a partial calcanectomy, because functionally they are pretty poor. And what we tend to do is we just curate the calcaneum as best as we can and keep the and just try to treat the infection. Now, saying that, there are situations where there's nothing you can do. And I think the question then comes in because there's so little knowledge and literature available. And I think at this point, my view would be that if we are doing a partial calcanectomy, muscle balancing would be such a huge problem that either you do the tenodesis in the front or the rebalancing is always an issue. And therefore, sometimes it's better for a below knee amputation for the patient. Now, I can understand in certain societies, amputation will not be as acceptable as in UK. And therefore, in some stages, a two-stage surgery where we debride and do the bone grafting to bring the bulk of it may be useful. In the midfoot, we didn't have any. Well, when I say didn't have any problems, we didn't have any sort of major functional issues because we tend to recreate the shape of the foot, and that's a primary aim. And we tend to avoid any muscle releases or tenotomies because of the fear of the imbalancing of the foot. Although I had one or two problems, but generally midfoot we are much happier than actually calcaneum. I'm not sure I've answered your question because I may not know the answer.
Thank you very much. Thank you.
Thank you so much, sir. Now we will move to the next speaker, Mr. Peter Calder from the Royal National Orthopaedic Hospital, London, UK. Mr. Peter.
Is the talk up?
Yeah.
Yep.
Perfect.
Okay, fine. Sorry. Well, thank you very much. It's a real pleasure and a privilege to be asked to talk. I was asked to give a very basic talk. We decided on osteotomy considerations and hardware in limb reconstruction. I'm just going to see if I can get rid of the speakers. There we go. Okay. So, here we go. So, as I've been introduced, I'm a pediatric and adult limb reconstruction surgeon at the Royal National Orthopaedic Hospital, which is situated in north west London. And today I was going to talk a little bit about osteotomy principles and then some deformity correction and the different types of implants that we can use to try and realign limbs. So always we start with Lizaroff and the principle of distraction osteogenesis, and to reaffirm what Professor Hosny said in his first talk, I think it's all about principles and applying principles, and we always fall back to Lizaroff's method, but there needs to be some innovation, and I think those who actually do innovate just need to be honest with themselves and make sure that when they present their results, they do so with integrity and honesty, and then we can know whether things are better or not. I think what Professor Hosny was saying about the new options of intramedullary lengthening is true, but there are some people out here that do look at their results and present their own results, including complications. But if we look at the tension stress effect, we can look at the experimental evidence that was done with stability of bone fragment, damage of osteotomy, rate of distraction, and rhythm of distraction as the classical way of producing new bone when you distract bone fragments apart. So what about osteotomy? Well, I thought I'd just look about the different ways of doing an osteotomy. So this is the classical corticotomy taught by Lizaroff, where you make a small incision over the skin and subcutaneous tissue down to bone. You then incise the periosteum and you elevate the periosteum, as one can see. And then you use these very sharp osteotomes to go down each of the cortices, attempting to preserve the intramedullary canal and blood flow. Then once you've loosened and got down to the back, you need to twist either your osteotome or actually grabbing the fixation of your frame above and below and then twisting, and that causes the posterior cortex to shatter. So that's the classical Lizaroff osteotomy. The Di Bastiani is similar, but you pre-drill. So you do go through the intramedullary canal with your drill, you perforate the posterior cortex, and then you do the same principle, putting in your osteotome and twisting. And here's an example of the femur, here's the example of the tibia. The final technique is to use a jiggly saw, and that's been mentioned by Professor Sharma in the last talk, where he did a midfoot osteotomy between two of the stirrup wires. And here you do multiple small incisions, passing the wire around the bone subperiosteal, so that you can divide the bone. And basically, the idea is to preserve as much of the soft tissues as possible. So one question is, well, what is better? So we looked at our results of healing. Anna Peak split up all the regenerate into zones and looked to see if there was any difference between using the Di Bastiani and a jiggly saw. And we found that there was actually no difference to the healing using that. So I think it's dealer's choice. My personal preference is to use the Di Bastiani technique. But obviously, I think whatever you feel accomplished doing, that's the osteotomy technique that you should use. So if we move on to the surgical treatment and deformity, what are our considerations? And as we know, there's lots of different tools, each has its own specific use. And again, it's just your armamentarium about what you want to use to get the best effects. And I'm going to look at some examples of guided growth in pediatric cases, acute correction with or without fixation, and we can use different sorts of things like staples and plates, and intermedullary nails. And then we can use external fixators, either monolateral or ring, and then gradual correction and lengthening. Obviously, has already been mentioned, external fixation and intermedullary limb lengthening. So we should first start with a little summary of what's normal and how do we assess deformity. And so we look at the standard angles. We've got the mechanical axis, we've got the anatomical axis, we've got joint line congruence angles, and we've got specific angles that can be made up. Here's looking at the mechanical axis. Here's the anatomical axis. And there's similar lines on the lateral. And by using these angles, which I'm sure you're all aware of, we can look at the chora, the center of rotation of angulation, to look at a deformity. And from that, we can then place hinges, or we know where to make our osteotomies in order to correct alignment without translation. So if we look at this, this is a model of a bone deformity. You've got a proximal axis, a distal axis, center of rotation of angulation. And if we have a bisector of the chora, and we know that if we place our hinge anywhere along that line, and then we break the bone at that level, by opening up, we can create alignment without translation. If we put the hinge away from the actual bone, but still on the bisector, then what we will gain is we will gain alignment, but also length. If we put it on the other side, we need to remove some bone so that we can actually do a closing wedge osteotomy and again get alignment. So that's osteotomy rule 1. If the chora is on the anatomical axis, osteotomy at the level of the chora will realign without translation if we place our hinge on the bisector of the chora. Okay, osteotomy rule 2. Okay, you can't put your osteotomy at the level of deformity. You have to put it at another level. Classic examples are when you have a deformity close to a joint, especially around the knee joint. An example would be Blount's, where you've got a deformity of the actual physis and the epiphysis and metaphysis. So the chora deformity is almost at the level of the joint. You can't do an osteotomy there, so you have to do it somewhere else. However, you do the osteotomy away from the chora, bisector of chora, but you still put your hinge on the chora, and that's the important thing. So you still get realignment with translate, but you get it with translation. So you make an S shape. Osteotomy rule 3 is when you put the hinge not on the bisector of the chora, but at the level, and therefore you get no alignment and you get translation. So if we look at some examples, so here we've got a Blount's disease. We've got the varus deformity. You can see the growth deformity on the medial side of the epiphysis, the metaphysis, and the growth plate. So we put some lateral plates in which straddle the actual growth plate, and this allows guided growth. So there's more growth tethered on the medial side, tethered on the plate on the lateral side, and over time you can see that the alignment becomes quite good. However, if you do an osteotomy, we would have to use rule 2. So we've analyzed our deformity. You can see where the axes cross right at the level of the joint. We've done our osteotomy distally, in this case a dome osteotomy, and we fixed it with some wires. However, from a technical point of view, the periosteum on the lateral side is very, very thick. So one tip, if you take away a little bit of the bone here, then that will loosen up that side of the osteotomy. So when you translate it laterally, you'll find that the actual tightness is compensated for, and you can move that bone quite easily. Here's another example, and you can see here, one criticism I would have is that all the wires crossing over are at the same level, so that could be unstable. So I would try and cross the wires across the osteotomy at different levels. Also, you can see from I've performed an arthrogram here, which delineates where the true joint line is so that you can look, because what you actually want to do is overcorrect into slight valgus. This is a Cosen's type fracture where you have a growth deformity into valgus, and we want to correct that acutely. So we can do a closing wedge osteotomy. We take a bit of bone away, and in this case, I've just used a simple plate to hold the fixation, and that corrects the alignment. What about intra-articular? So you can look at your joint convergence angle, and you can see where there's a deformity within the joint itself. Look for subluxation and incongruency of the condyles. Here's a classic example in Blount's where you've got deformity of the medial tibial plateau. we can see that we need to raise that plateau to reconstitute the tibial joint line. Here's an example. Okay, so you can see where our medial tibial plateau, this is the pagoda effect that's been described. I can see I've done an osteotomy here. How do I do an osteotomy? I pre-drill it. Then I swing my X-ray round to lateral. And as I pass my osteotome, very sharp osteotome through the posterior cortex, I can actually check that I'm not hitting it too hard to make sure I don't go, dramatically through the posterior cortex. Once I've opened that, you can hinge it. It doesn't matter if it cracks, it normally doesn't actually displace, and you can see I can hinge it, restore the joint line. I've held that with some fibrillar graft, and then we can analyze our deformity. There's our joint line, there's our anatomical or mechanical axis, which is coincident in the tibia, and there's our residual varus. And in this case, I fixed it with a combination of wires and half pins, and then we can correct that deformity using osteotomy rule 1. There's my frame, there's my alignment, and there's the end result with the mechanical axis now passing through the center of the knee. Even in the more complex, the same principles as Professor Sharma said in the last time, write down your deformities. What do I have to correct? So I have to correct the incongruence in the joint. I've got residual varus, and I've got an apex posterior deformity here with recavata. So I've done the same thing. I've reconstituted the joint line by doing an opening wedge. I've fixed that with the wires. What you can see here is what I tend to do is the wires first, especially if there's a small medial fragment, and then I place the ring onto the wires. I put all my wires in first. I can't get a medial half pin in. So what I've actually done is put a lateral half pin in. Then we again reanalyze our tibia. We do an osteotomy. And again, we can correct alignment with our frame, and that goes on to heal. If we look at the sagittal plane, we can put the same numbers down, and we can look at fixed flexion deformity. And the way that we can do that is taking, we can do shoot through lateral x-rays in maximum extension. This is a common thing that I do. And then if you take a line on the anterior aspect of the distal femur, proximal aspect of the tibia, they should be in a straight line. But of course, you can get deformity either of femur, tibia, combination of both, or joint. Now, in pediatrics, we often create a deformity to treat a deformity. And here's somebody with cerebral palsy. And what I've actually, and here you can see the fixed flexion deformity. And what I've actually done is put some anterior pediplates in and use this own growth to grow the distal femur into extension, which then creates a straight knee. But I'm creating a femoral extension deformity to correct the fixed flexion deformity of the tibia. I can also do that acutely. Here you can see an older patient where we haven't got enough growth to be able to do that. So what I've done is extension osteotomies. You also have to look at the patella because you may need to do an advancement of the patella, the tibial tubercle to tighten up the quadriceps, or you can shorten the patella tendon, which is what I did in this case. Often patients present with tibial growth arrest, and you can see here a significant recavatum deformity. So again, it's a similar principle. You put your fixation above and below, you do your osteotomy at your cora. You can see that this is the deformity that this lady compensates for her recavatum of her tibia by flexing her knee. So we need to encourage her to stretch out the posterior capsule, which has got tight because of that compensatory position. And here you can see with time, with the frame, I've corrected that deformity. And there we can see the clinical picture with the knee restored into a normal alignment. And then we've done some lengthening to equalize the leg length, and you can see that we've got a good result from that. Fixator assisted deformity correction. So this is not a new technique. There are several papers from years, one from Rosbrook and one from Paley and Hertzberg, 1997 and 2011. What are the surgical principles? Well, we want to improve our accuracy of limb deformity correction, and then we want to use internal fixation so we don't have the frame on for long periods of time. We utilize the adjustability of the external fixator so that we have good correction. And we optimize bone healing by being able to do all of this with percutaneous techniques and not a lot of soft tissue stripping. We can remove complications associated with the external fixators, and we've talked about pinch site, joint stiffness, and also the mental well-being, which is obviously a big thing at the moment. So here's a fixator-assisted nailing. You can see the principles that you put on a monolateral fixator. It's important to make sure that you put your pins proximal enough with the nail pre-measured. Look at the entry point of where your nail is going to be. Look at the position of the pins proximally, so that basically when you put your nail in, your half pins are not actually touching. And then it's suggested that you do a dome osteotomy, because we're going to do osteotomy rule 2. We're going to have displacement. Okay, this is a technique where you can actually just put something like a Rancho cube, attach it to where the deformity is, and then you can do your pre-drill through small incisions. However, I would put to you that look at this dome, look at the arc of the dome, and in effect, I believe that it's almost a straight line. So I'm not absolutely convinced that we're doing a perfect dome, and therefore I'm not sure you need to go to that length to be able to do that deformity correction. You can then see how the deformity is corrected acutely with the external fixator, and this is held, and that allows you to then put your nail into a good position and fix it, and then you take it off. You can use polar screws in order to hold the nail to maintain the position. Here's an example using a tibia, same principle, same position, same use of polar screws. Here's some of my cases. Here you can see a deformity. They have fibrous dysplasia and a fracture malunion. If we analyze it, we can see there's a proximal cora, a distal cora. And what I decided to do was correct the distal cora acutely with a closing wedge osteotomy and plate fixation. That left us with a proximal cora and shortening. I then put a half pin in, as you can see in the posterior cortex. I do my percutaneous osteotomy. I correct the alignment. And in this case, I've inserted a lengthening nail, a precise lengthening nail, and we can see that there's a trapezoidal opening wedge with a restoration of alignment. Here's a case where I used a retrograde approach. This is a patient who's got fibula hemimelia. If you cover over the mid-diaphyseal deformity, there's reasonable alignment of the tibia. So the valgus is coming from distal femoral valgus, which is very common in congenital limb deficiency due to hyperplasia of the lateral femoral condyle. You can see it's very narrow. So I used a reverse planning technique, which is being shown by Baumgart. And the idea is that you place the femoral head in the optimum position to where you want the actual femur to look at the end of your lengthening. You then have an anatomical axis of the nail insertion. You bring that down to create a deformity of the osteotomy in the supracondylar region. And that is the displacement that you need at the time of insertion of your retrograde nail, so that when you finish your lengthening, your mechanical axis has been restored. So here I've made my analysis of deformity preoperatively. I put in my guide wire to put my entry point for my nail. I then percutaneous do my osteotomy in that super region, and I'm using a fracture reduction position here. And the reason I've done this is because that allows me to identify where my half pin is going to go distally, and I can put a half pin behind my nail. You could put it above your nail, below the nail. This is so that the nail is not going to be blocked by my reduction device. I then do my osteotomy, and you can twist your osteotome around to displace the fragments. I can then put in my, I can lock that with my half pin distally and proximally, and then I can put in my guide wire, and then I can insert my nail. I can put in my blocking screw, and that holds the position. So you can see the displacement of my deformity, and then following lengthening, you can see that I've restored the anatomical lateral distal femoral angle to normal, and I've restored length. There are some nice papers on where to put the blocking screws when you're considering lengthening, and basically it's the reverse thumb rule, where you have the olives for deformity correction with a frame, you put your polar blockers the opposite side. You can use a hexapod device when you need to do more complicated deformity corrections, including rotation. Here's a patient with a very rare syndrome, and this patient had retroversion, varus, and shortening. So what I did was you put these a hexapod structure in, and if you look at the position of these half pins, they are straddling the patella into the medial and lateral femoral condyles. You can then see that I've placed the ring proximally by using Rancho cubes, and this is because, and then you can see the proximal Rancho cubes here. This is to allow me to be able to do my osteotomy and my locking of the nail distally. You can see I'm putting some proximal locking bolts in here, and that's the end result. So you can see that the osteotomy has been displaced to correct the rotation, the varus, and the angulation, so that when we finish the lengthening, we've restored the anatomical axis. That results in healing, and then we do a residual deformity correction distally of the tibia using just a simple hexapod. Fixator assisted plating, I don't really do this very much, and so these pictures are taken from one of the papers, and it's exactly the same principle. You do, your approach, you either do your frame medially or laterally, depending on which way you're going to put your plate in. You can see the locking plates offer that beautiful example of an internal external fixator. You can see the percutaneous application, so minimal soft tissue stripping in effect. And you can see the results in this paper. And if you're going to use a hexapod, this is the way you position your hexapod. There's some good pictures in the Bristol paper, which I mentioned earlier, where you can see how to position your frame to, again, avoid impingement of your internal fixator. And this is a good picture showing you, again, how to put your frame on. Just a point of caution, in severe valgus deformity, if you want to correct deformity, so here's an example of our learning curve with the precise lengthening nail in the tibia. The soft tissues are very tight, which is well known if we go back to Lizaroff principles with the lateral compartment and the posterior compartment. And you can see that during the lengthening process, the patient's tibia has drifted into valgus. And so what we did in this case, we wanted to do a fixator assisted nailing to put it in an optimum position, but I would recommend you do a perineal nerve decompression first. And this is the steps of the perineal nerve decompression, where you're releasing the impingement of the nerve as it goes around the fibular head and through the anterior compartment with the interosseous membrane. You need to release all of these to make sure that the nerve doesn't get pulled tight across these structures. And you can see that we've done the perineal nerve decompression. I've used a hexapod structure to be able to put the tibia straight, and then I've put a nail in to hold that position. So percutaneous osteotomy, acute correction, stable internal fixation, pin placement to avoid implant impingement, osteotomy level, producing an arc along the circumference, and then preoperative planning, outcome rotation maneuver to correct deformity, and the perineal nerve decompression. There's a summary of that fixator assisted. What about bone transport? So in my practice, there was a big call to do a lot of bone transport for excision of osteofibrous dysplasia. So it's thought to be a malignant change to adamantinoma. So the tumor surgeons at my institution were very keen to excise the whole of the osteofibrous area with an extra periosteal dissection. So I undertook quite a lot of massive bone transports where the bone defect was about 10.8 centimeters as a mean. And we found that there were lots of complications, including infection, deformity, docking site, non-union was a big thing. So my current strategy, here's an example of adamantinoma with both the tibia and the fibula actually involved. There were changes of adamantinoma, so there was a malignancy there. So what we do an extra periosteal dissection. So I apply the frame first. You can see the transport segment proximally is not fixed at that time. We then do an extra periosteal dissection, and there's the defect that's left. That can be repaired. And then I fix the proximal segment, which you see on the right-hand picture, and then do an osteotomy for lengthening. There's our post-op frame. And again, like any docking segment, you can just pull it down. Now, I have used wires in the transport segment. I've used half pins in the transport segment. I'll just go back. One of the things I try and do is put either the half pin in line with the incision that's used for the bone segment excision, so that when the half pin gets pulled through the soft tissues, it scars through that, and actually is easier to pull through those tissues than through virgin skin. We did a bifocal segment where we excised the fibula at the time of docking. If the fibula is not a problem, then I do an osteotomy of the fibula and I acutely shorten 1 centimeter. And this allows me to freshen the bone ends of the tibia, do a docking procedure where we've got good bone on bone, good compression immediately visualized. By doing an osteotomy of the fibula, you stimulate bone healing again, and then you continue the distraction of you turn it into a bifocal treatment where the proximal segment is then continued to lengthen to restore length. And there you can see initial post frame. So good counseling is needed because of the duration. Most frames are on for at least a year. The stacked TSF, you can do that with wires or half pins, as we said. You lead by the nose so you can pull it down. When you do the docking, I'm quite keen to do an acute compression and bifocal lengthening, freshen the bone ends. Fibular osteotomy re-stimulates the body to start healing again. And then finally, look about the lengthening nails. I know Professor Hosny has spoken a little bit about this. You know, it's an external control of an internal device. You avoid the use of the problems with the pins. You theoretically can get more physiotherapy. And we looked at our results, and we published quite a few papers which show that you can get good range of motion, good bone healing, cosmetically appealing, and patients seem to like it. So here's a few examples. Here's a growth arrest in a 12-year-old child. I've done a trochanteric entry to avoid APN, 8 centimeters of lengthening. Look at that at 3 months, fully healed, back to full sports. So in summary, we talked a little bit about osteotomy technique, and then I've gone over implants that we can use to correct deformity. We've looked at, our coras. We've done acute correction. We've got wires, plates, fixator-assisted nail and plating. We've got gradual correction using external fixation, and finally we've got intramedullary lengthening nails. And there's some pictures of me in the summer of this year, and my wife in the tunes that we were taken to are absolutely amazing. Thank you very much.
Thank you so much, Mr. Peter, for this very interesting talk, and thank you for your picture besides strengths. It's a nice picture. Thank you so much, sir. Dr. Ahmed, if we have any questions to Dr. Peter, I think we have questions from our dear colleagues.
Thank you, Mr. Peter, for this. This should be limb reconstruction from A to Z. This should be the title. It's not osteotomy, it's everything really. Really wonderful. So one question from one of our colleagues, that how to deal with the deformities from the joint, meaning joint laxity. Really, it's a very good question, because with long-term genovarum, we always have this issue. Does we need any soft tissue reconstruction in terms of collaterals or whatever, or should we just fix the bone first and then reassess the joint stability later? What's your opinion about this?
So there's a big, so if we think about congenital limb deficiency, then those patients often have absence of their cruciate ligaments. Now, there are some that advocate reconstruction of some sort of intra-articular ligaments, like a cruciate ligament, where you use the tarsal fascial lata and you can plumb it through the actual posterior aspect of the femur to the tibia. There is no evidence out there that gives more stability to the joint, and but there is some work being done in Sheffield looking at the stability of the joint and the risk of dislocation after the ligament's been reconstructed. So I think that there is, in that particular group, I would still advocate concern over the risk of dislocation during lengthening. And in the children especially, I would bridge the knee. If I was to use an intramedullary nail, I would not be doing it in the younger child, I'd be doing it in the older adolescent child and adult, where you can have a lot more discussion. And again, I would not use a retrograde approach in the femur. I would leave length in the distal femur to be able to apply a bridging frame if there was any concern about subluxation. So that's one thing. Other conditions such as hypochondroplasia, where they have an inherent joint laxity, where there is a lot of joints. And again, if I was concerned about joint laxity with associated bony deformity that I wanted to correct, I would have little hesitation in bridging the knee. But in these conditions where I'm not worried about so much dislocation in the AP plane, but dislocation in the varus valgus, I would leave those hinged. So I'd allow flexion, but they would protect against that. And the other thing I've found is that when you then take the frame off, they've often stiffened up their knees quite a lot during that process. So the final thing is about the fibula position. And if you've got a fibula, so you have a joint, the fibula should be here. If you've got an overgrown fibula with the lateral collateral, then I would also consider doing a staged approach where you pull the fibula down to a normal position with the frame with lengthening. And then I would fix the fibula in a second operation and then do a fibular osteotomy and then carry on lengthening. But you can do ligament reconstruction, but I think I would, and I know that there are people who would advocate that. I think you'd have to decide what you want to do. I probably would bridge and deform first and then look at ligament instability afterwards.
One following comment in the same area. When with normal genovarum in 40s or whatever, and you just correct it, some of my dear colleagues, knee surgeons, they stress on the point that you should release the adhesions on the medial side, release the MCL. They advocate that the correction from varus to valgus acutely would not be good if you are not doing the release on the medial side. Of course, they do this when they do the standard medial approach, Tomoflex plate, open wedge osteotomy. But they stress on the point of soft tissue, and I didn't get this when we do this gradual or even X-fix assisted with other techniques. So what's your point about this, releasing any of the medial structures?
Well, if I was going to do distraction osteogenesis, I wouldn't do it, because the whole point of doing distraction is you're doing it gently. If you're going to do it acutely and you're doing an opening wedge osteotomy, I presume you're doing it for medial joint arthritis, are you?
Yeah.
Well, then you're going to, I mean, if you're going to do it gradually, so this is the argument I have. What is the principle of the treatment? Is the principle of the treatment there's no arthritis and you want to prevent arthritis, so you're going for an accurate position. So you can either, if you feel good, you can do an osteotomy acutely with a Tomoflex plate, small medial Tomoflex plate. I have to be honest with you, I'm not that convinced they are that accurate. Versus, if you're good at it, you're good at it. Versus you do a 2-ring telespatial frame and you gradually correct it till you get it absolutely perfect. In which case I wouldn't do any soft tissue release. But you've got to do a soft tissue release if you're going to put the plate on, because you're going to be doing that medial approach.
Yeah.
And the knee surgeons are always going to say that you need to do a release, because they've always done a release because they haven't used the frame for the correction. So I think it's I would do what you think is right.
Yeah.
But I wouldn't do a medial collateral ligament release for a frame.
Yeah, that's another question about the guided growth for Blount disease. I assume the point that how you would pick the patient, or should this be the first step?
Yeah, so I think that so it's a great question. I knew that was going to come. So guided growth. So it's all about the physis and whether it's all about the concern about, because obviously guided growth is not going to work if there's a bony bar. So if that's the case, then you've missed the boat. You can't do it. The guided growth is good for those cases where it's relatively minor and you want to correct it, and also to prevent getting worse. So you can do it if you're worried about the growth plate, if you've done a CT scan or an MRI scan and you're worried about the physis, but there's no bony bar, there is no harm, but it may not correct. One of the other ways of doing it, if the deformity is quite severe, another thing that I've done is I do the dome osteotomy, which I showed, so that you correct it, but I also put the pediplate in to the lateral side, because I'm not sure if the growth plate is viable medially. You then watch the growth plate, and if the screws start to diverge and it grows into valgus, then you know that there's growth from the medial side, and you can take the plate out. But if the medial side isn't growing and there's no divergence, then the plate will stop you getting recurrent deformity. So if you've got a really big deformity, I would do an acute correction and I'd put a plate in. If I've got and it's dealer's choice really. It's what you feel comfortable in. But there's a good paper that John Herzenberg was part of that was presented many years ago in Oslo, where they put all of them together. And again, they said that guided growth is an option, but I would like to get the leg straight as soon as possible, if I was to be honest with you.
Age limit for this? Would you do this for 4 years, Blount, with grade?
So again, we know historically, the older the child is, the worse the outcome is going to be. So I would probably be guided growthing, around that age. Yes. If you get to 6 or 8 years old, then you probably missed the boat, to be honest with you.
Yeah, that's perfect. The last question, that the same colleague asked for your email to share with you some cases, if you don't mind. Shall I give him your email?
Yeah, definitely. Yeah.
That's all right. I will reply to him.
Yeah, but you have to give an opinion as well, Arvid. I'm not having it all on my own.
Oh, that's what I'm not giving opinion after you. Come on.
Yeah, no. If they want to, yeah, fine. And if it's very, very challenging, I'll take it to our MDT with Mr. Goodyear and Mr. Wright, and then we can go from there.
Yeah. Thanks so much. So we have been late a bit for what I've told you in the previous episode. So sorry for the late finish for you.
Is Ashraf, are you talking now?
Yes, sir.
Yes.
Thank you so much, Mr. Peter Calder, for this very interesting talk. Thank you so much for being with us, sir. Thank you so much.
Well, if Ashraf is talking, I'm going to watch his talk.
Yeah. Our last speaker will be my dear friend, Dr. Ashraf Azer from Liverpool. My dear friend, Dr. Ashraf.
Thank you very much, Professor Al-Ashraf, and lovely talks from Peter and Mr. Sharma, and obviously Professor Hosny. It's amazing as usual. It's my talk is coming from a different perspective altogether. I was asked by Professor Ashraf and Dr. Sheikh that we need to develop service in Egypt, being myself an Egyptian and passionate about rehabilitation post-amputation. So I was asked by Dr. Sheikh just to give us some talk about the general view of MDT rehabilitation was functional amputation. It's going to be a small one. But this is what I work is actually not in Liverpool, it's Merseyside, it's a Wirral Limb Center. And this is our team, our workshop. I cover this area, or we cover this area, is Wirral, Cheshire West, Holton, Warrington, St. Helens, part of Knowsley, part of Crewe, part of North Wales, and is about 1.2 million. Just as a general principle, we classify amputation as it is destructive, mutilating, and irrecoverable. Once you've done it, there is no coming back. But in the meantime, amputation saves life, it relieves pain, and it's a new start for the patient. And this is a concept when working for the NHS, this is what will drive us to make a patient a person again. By the way, it's not my words. It is Lord Holness, who is bilateral amputee himself, parliamentary, and he said that rehabilitation converts a patient into a person. Amputation in general should be planned, timely, and holistic. In the recent Vascular Society meeting where we shared in that, we agreed that amputation should be done by a senior person, whether vascular or orthopedic, and should be done in daylight, despite whatever, and should be well planned and discussed with rehabilitation. Why is that? Because as a team, the functional outcome to make a patient ambulant again, to be productive in the society, our goal is just to bring patients together to walk again. And we want to mimic this service to Egypt. So our team consists of a rehabilitation physician, prosthetist, admin team, nursing, psychology, occupational therapy, physiotherapists, and a user group of the patient themselves. They're quite integral part of the team. But also, this is our local team. We cover an area of 1.4 million. We cover Wirral, Chester, and Warrington Trust, but they have an arterial center in the Countess of Chester Hospital. We have excellent relation with our orthopedic, bone reconstruction, pediatrician, or pediatric orthopedic vascular team, endocrinologists, and we are integral to the diabetic foot clinic, because we can plan even for the minor toes amputation, mobility after amputation. That's why I asked Professor Sharma about his views about partial calcaneectomy, which actually it's a common practice in our locality, which we don't get in good results and poor function after that. We have a good relation as well with our regional pediatric service in Alder Hey. I'm sure you know Durai and Nayagam, Badri, and you know that, and I've met Dr. Sheikh there as well in Alder Hey when he was doing his fellowship as well. And we gain a lot of knowledge, and we share lots of patients with very complex needs, and we treat them. We have an MDT of orthopedic consultant, vascular consultant, plastic consultant, and 3 rehabilitation consultants from different locality, and we plan amputation around this area. Also, we have a good relation with the plastic team in a regional plastic unit, which is in Western, for very complicated case which need amputation or for pre-planning amputation. So our practices in that area, we actually receive plenty of pre-amputation consultation, either for children or for children with congenital deficiencies. And I believe my colleague Sidki Ahmad just deal with a lot of cases with Peter, is that right? Ahmad Sidki, and he's a good fellow, actually, he's quite good. And I think he will come with us next time maybe. And we see the patient pre-amputation, we'll plan for the amputation, and then we have 3 different localities between Chester, Warrington, and Wirral. Each one has a team. So we treat the patient post-acute immediately, day 2 post-surgery. And then we see them as an intensive rehab post-surgery in our locality. And then prosthetic rehab, very intense, settlement back in the community. I never discharge a patient. We don't discharge any patient. Might be discharged from physio or from OT service or community, but it never discharged from our side. When we see the patient, it's a very holistic approach for rehabilitation. So we don't treat amputation, we don't treat a stump, we treat the whole person. So people with having cognitive problem, learning disabilities, CVA, dementia, psychological disturbance, all sorts of musculoskeletal problem, muscle imbalance, neurological disorders. And don't forget that we deal with the remaining limb as well. We deal with the wound promptly from our side and liaising with a different other surface. Once we start with a basic post-amputation walking aids. So the patient will get this as soon as 1 week or 10 days after wound healing, or even without wound healing, which call it pomade or femoret for below knee and above knee. And also we have similar things for upper limbs as well. Once we treat this patient, we have his cast done, and then first prosthesis, we treat him. The prosthesis will belong to the NHS, and the patient has to come and commit himself to the intensive work to walk on even ground, uneven ground, slopes, stairs, steps, with or without walking aid, till he's safe to go back home. We'll give him the limb, but we still see him every 3, 6, 9 months and 1 year. The reason is we set goalposts every time, we change the activity level, we can change the componentry. And nowadays, thankfully, the NHS allowed us to use a very high-tech microprocessor knee, and actually now it's coming to hand is the microprocessor hands function. So our team will have this input all the time. We have medical, physio, nursing, OT, psychology, wheelchair, orthotic, social service, and community. Again, we don't discharge person. The reason I'm giving this example, because as well, we share teaching for FRCS also, for Merseyside, Lancaster, and vascular FRCS exit exams. We have joined project between different limb center. We are in the executive member of the British Society for Rehabilitation Medicine with special interest group in amputation. We have collaborative work between us, Liverpool, Manchester, Preston, Stanmore, and Norwich. It's a very good network to share experience. We did a course in Egypt, and when I visit Egypt, we see patients regularly. Either like, friendly referral, or like Dr. Ahmed and frequently just, can you give us an opinion about this? I have been there, and we give a long course with our team. We got a team from here, actually from Manchester, and we went to the military hospital, which I think this is the most, let's say, equipped hospital to deal with amputation. But we found that we have 3 centers related to military and plenty of private practice, but it is prosthetically led. Unfortunately, the prosthetists are not formally trained. We don't have a university or an academy to give a graduate a prosthetic degree. It's mainly by generation to generation, that's it. So it's eyeballing. We don't have Strathclyde or Salford University or Liverpool University for prosthetists. The leadership of a team to provide prosthetic rehabilitation is vague. I'm talking about this as an Egyptian, not now, I'm not comparing things, but what I need is just to provide data to have a very well-established service in Egypt. Hopefully we'll do this soon, Dr. Ahmed. When we discussed this, we found plenty of surgical problems, as you see, which will not be attended to. Not because of that, not because of the, I think it is because of lack of knowledge. And amputation is considered in Egypt at the end of the road. So it's not, it's a waste of time. Let's do it and get rid of the leg, and that's it. After congenital, bone reconstruction, vascular. So when we face that, we felt like kind of unpleasant post-operative kind of, or no planning at all for the amputation, either below or above or upper limbs. I have plenty of picture denoting that, but we decided, let's go and correct this. So we have things like that. Surgical technique is not great because we notice the lack of communication. Therefore, Professor Ashraf and Dr. Ahmed said, let's build a team and bring good knowledge to mimic the service what we do here, and let's provide a good service for people after amputation. Our future plan is to do collaborative work. These are clinical, teaching, but we're having problem with accountability and clinical governance and development a team, because I'm not really sure, maybe Dr. Ahmed or Professor Ashraf will tell me, the essence of rehabilitation is not that clear. It's been run by rheumatologists more than anyone, and rehabilitation is being summarized to a physiotherapist who provide a sort of exercise, not planned on scientific mind or any planning. So we wanted to correct this. We found these challenges, like how can we identify the needs and resources in Egypt to provide that? And acceptance from colleagues, like thankfully, Professor Ashraf, Dr. Ahmed just were kind of leading on that. They said, let's accept our problems and walk and do something proactive to provide a service in Egypt. But who will provide the leadership? This is the main thing. Is it the vascular colleague, the orthopedic colleague, the rheumatology colleague, physiotherapy, or the private sector where they provide loads of unplanned, unscientific procedures for no reason, just for money. I remember when I was in Egypt the last time, someone just asked me to, because I had what you call it, a company, Azer company. Azer is well known for orthopedic as well, prosthesis. And some guy just rang me and said, my dad just need his bilateral above knee amputee. He wants to have 2 very expensive prostheses. But I said, we don't work it this way. Let's bring your dad, examine him, and see what we can do. The poor man was 77, ejection fraction of 20, is vomiting all over the world. He's completely demented. And someone told him, I'll provide your dad with 2 Azer, 30,000 each. So I said to him, it's not on. It's not on. This is a problem we face. Lack of scientific mind, lack of planning, lack of communication. I asked one of the military people there, and I said, well, just let me get in touch with orthopedic surgeon related to the factory or to the military service, so we can discuss cases as we do now, and we well planned for amputation. He said, no one is ready for you to do this. And I'm not really sure this is a good or bad thing. That's why we need to know who's going to lead, who will take the accountability, and who will provide the funding. We're lucky that we have the NHS, but the private here is well structured as well. It's not like everyone would like to do whatever he likes. But we offering people to come to England. We offer them to do the course in Strathclyde or Salford and to do the full course of prosthetics. And then we build up a new team, which can involve pediatricians, diabetologists, bone reconstruction, vascular, so to provide a better and functional outcome for our patient. So this is my view. This is my ambition. I'm quite up for it because we want the best. And obviously, with all your help, Peter and Professor Sharma, Professor Gamal Hosny, and Professor Al-Ashraf, we can develop this service. If you want to, we can develop it. We want the best for our children, our surgeons actually, to gain the knowledge, our physicians, to provide a world-class, class 1 amputation service. This is only an overview. We didn't discuss in details whatever we do here from different issues, and I'll end up by saying that. And thank you very much for listening.
Thank you so much, Dr. Ashraf Azer, for this very interesting talk. And with your help, we can overcome all these challenges, sir.
I'm up for it. I'm up for it. That's why I'm here, to be honest. I'm not comparing. I'm just trying to say, we're not comparing, we're exchanging experience. We want the best for the country. That's all.
Yes, sir.
That's what I'm here for.
Yes, sir.
Before I die.
Your effort is very appreciated, sir. Thank you so much, sir. Dr. Ahmed, we have any comments on the talk of Professor Azer, or any questions for him?
No, I think we are okay. Just we are trying to spreading the word about the idea of rehabilitation and the holistic approach of the patients pre-operative and post-operative, because there is sometimes an idea that the rehabilitation is something that's post-operative, but from what I have in Stanmore and in Liverpool, it's really a very pre-operative thing, especially in complex cases. So that's the whole notion. Peter, you're raising your hand. Go on if you have any comment.
I was just going to make the comment that we in Stanmore, we do have once every, it used to be quite often, but now we can do it once every 3 months, where we have complex patients have a combined limb rehabilitation and surgeon and prosthetist and physiotherapist at the same time. And then the patient comes in and sees everybody at the same time, and that works very well. I don't know whether it's worth considering that, in Liverpool as well, trying to get the surgeons, so you have a one-stop clinic rather than, having to refer to this person, that person. I think that the big challenge is going to be the cultural acceptance of the treatment. And, even in the United Kingdom, those people who culturally find it challenging to lose a limb, it's very difficult for them to accept it and move on. I've given quite a few talks in Egypt at certain meetings about amputation, and when I ask the audience who does amputations, there's hardly anybody. It's not a common procedure. So getting the rehabilitation is even more challenging, because you haven't got.
It's at least it's not part of our orthopedic training. So in Egypt, the general surgeons, vascular surgeons, these are the people who are trained, and they are doing this either for traumatic causes or for other causes. So it's not part of our training. And the major challenge is the idea of rehabilitation, or the need for extensive, as Dr. Ashraf said, really, there is no such charge from this service. They are just follow up all the time. We have Prof. Gamal here.
Ahmed.
Gamal, you have any comments, sir?
Yes, it was part of our training long time ago to do an amputation.
Wow, I missed it. Sorry, Prof.
Because you are too young for me. That's it. It was part of our training. Yes, but the problem is, I'm one of those people. I have the same ideas. I have the same roots. I'm not going to change it, because perhaps I'm one of them. I can't change it. I was born like this. My father was like this. I cannot change it. I cannot accept amputation. They cannot accept amputation. We all know that amputation is a reconstructive procedure. That's why most of the cases referred to me, they have the decision amputation by the group of surgeons before. We're trying to avoid amputation but it's not an option. If it's an option, it's not an option for almost all the people here. If it's a must, it's a must. This was no other choice, no other choice. But as a choice, it's not a choice. Don't try it. I don't try it.
Yeah.
Because I'm one of them. I have the same beliefs. I have the same ideas. I have the same culture. I have the same roots. I understand them quite well. I'm one of them. So don't talk about changing the concept of the people, because I'm one of them. I'm not going to change them because I have the same beliefs. The second thing, you know, the revolutionary ideas, and we have a seminar in our annual meeting, the 74th annual meeting. One of the seminars about the use of prosthetics in amputation, and they are going to talk about the bionic hand and the other methods, the new technology. I'm just telling the people that it's not the same way that we have learned it before. There are new advances. If you have a below-knee amputee, you can run 10 seconds per 100 meters. We all know this. But unfortunately, these cases are damn expensive for the people here. So when we give them the choice, you have to know that it's damn expensive for them.
I think
It's not the same choice like in Germany or in England or something like this.
No, so Gamal, when I was in my fellowship in Kurgan, it was exactly the same principle. And there it wasn't a cultural thing, it was a functional thing. They didn't have the prosthetics, they didn't have the rehabilitation. So their severe lower limb deformity, they would reconstruct to give them a limb to stand on because they had nothing else. And I completely agree with you. I would never try and change anybody's culture or anybody's beliefs. What I do offer is what are the options. So you have all these options, and it's not what can we do, it's what should we do. So we have a long discussion on what our options are, and then a time for reflection for the people to consider what their options are, and they come back and then we have a chat. Now, I have children who I have done multiple limb lengthening and deformity corrections, and I've had children who have come with severe lower limb deformity, and the parents have asked for an amputation. So I wouldn't push it on anybody, but you know, I think you're absolutely right.
I have to agree and disagree with something. Sorry, I have to say that. Part of it is the culture. Now things have changed, not only for prosthetic provision, but people now are open to the open internet. They read about stuff. They need how it is a new start. Even in England here, everyone comes in with a Google list of so many things he's ready to understand. This is an issue when we don't have an MDT. We have the same MDT like you, Peter, in Alder Hey. We have all of us gathering in a big room every 3 months, and also with a plastic surgeon, and also with our prosthetist and MDT. We gather together and we try to say it clearly to the patient. These are the options. Think about it this way. Go and think about it and come back to us again. We have this option. We can provide this, or we cannot provide anything at all. Or we can, even prosthetically, we cannot do anything for you. At least the patient has explored or been given all the opportunity how to manage his life post-amputation, with pain, without pain. Like, it's a good thing to have a reconstructed limb, but it's a painful limb at the same time.
Well, I mean, but Ashraf, I think that the patients have to be involved in their choice. And I
Absolutely.
think that my experience of visiting Egypt is the patients don't want amputation.
Yeah, that's fine. We have people, like I have 2 patients, 2 is PFFDs, and one opted for a science. Well, we went through the classification and we went through the degree and we spoke to the surgeon and everything, and both came with the decision, their next of kin want to have a science, because she had as well a long-term fibular deficiency, and the other one opted, no, we have a long-term less lengthening the bone, and she's still there. So I respect both. I don't offer anyone anything.
Ashraf, I have hundreds of patients. Egypt, from Sudan, from Yemen, from Saudi, Iraq, Morocco, and they all have PFFD. And for all of them, we don't have this option. They don't accept it. Unfortunately, I'm one of them. I don't accept it too. I can't change my roots. I tried, I failed. you know. So I have hundreds of people, and that's why we try to change everything, you know, just we are not going to judge the people, or we don't judge them. We are trying to make their life easier, happier, and more comfortable. That's why we do now. We are trying to improve their lives to a better solution because we don't have this choice. So we have one choice. Perhaps this is right. For the science, perhaps when you try to do more constructive procedures, to have in 5 years, 100 years, you have better. You remember that. A few years ago, we were just doing amputation for congenital subarachnoid tibia. If you fail 2 times, you know, no one talks about this now, about doing amputation if you fail in treatment of congenital subarachnoid tibia. So perhaps what we do now is better for the science, that the people, they don't accept amputation, and we try more and more the reconstructive procedure, especially the congenital deformities in this area, in Egypt and others, because we know that we have consanguineous marriage in 35% of marriages. In Saudi, is more than 55% of marriages. So the number of congenital deformities in this area is huge. Most of the, you know, the statistics are coming from the States and England or something, but we don't have statistics, real statistics of the, you know, that we cannot compare it. When you say about tibial hemimelia 1 per million, this is not true in Egypt. This is not true. We have many cases of tibial hemimelia. So this, why don't we use this for the sake of the science? You know, that's why we try to develop more and more with the experience, and we publish it. We publish the complications, publish everything. Perhaps with the future, we can make this comparison better. Perhaps with the future, we improve things for these patients. Perhaps it's going to be more than reconstruction than with the amputation. We don't know for the future.
I agree with that. To be honest, I'm not disputing the fact or which is better, reconstruction or amputation. This is not me for me to say that, but I'm saying about life after amputation. How can we improve functionality if the decision to be made is just to go for an amputation? This is my aim. It's not, you know what I mean? Definitely, I have no say in saying reconstruct or not reconstruct. This is not my say. This is your say, actually. So, yeah.
Thank you so much. Professor Hosny, you have any other comments, sir?
No, thanks. This was a great meeting. Thank you.
Yeah, thank you so much.
Thank you very much, everyone.
Finally, I would like to thank our eminent guest speakers, Professor Gamal Hosny, Professor Hemant Sharma, Mr. Peter Calder, and my dear friend, Dr. Ashraf Azer. Many thanks to my dear friend, Dr. Ahmed Sheikh, for organizing this fruitful scientific webinar. Thank you so much, and see you, and have a nice time. Thank you so much.
Thank you. Bye now. Nice.
Thank you so much.
See you.
Bye now.
Take care. Bye. Bye.
Thank you.
Bye.